Artificial Intelligence Doctor. User question. Does upgrading to a dual-chamber leadless system, Abbott Aveir DR or Medtronic Micra AV2 plus VR2, versus single-chamber replacement or CSP improve stroke volume, ventricular synchrony, NYHA functional class, and patient-reported quality of life scores over 24 months in older adults? Gemini AI. This is an excellent and highly relevant question as dual-chamber leadless pacing, DCLP, is a relatively new and rapidly evolving field. While the long-term data, 24 months or more, is still emerging for DCLP systems, particularly with direct comparisons to single-chamber leadless pacemakers or conduction system pacing, CSP, we can draw some conclusions and expectations based on available evidence for existing systems like the Abbott Aveir DR and Medtronic Micra AV2. Key concepts and expectations. AV synchrony and hemodynamics. The primary advantage of dual-chamber pacing, whether transvenous or leadless, over single-chamber ventricular pacing, like the original Aveir VR or Micra VR, is the preservation of atrioventricular AV synchrony. Maintaining AV synchrony is known to improve stroke volume and cardiac output by allowing for proper atrial kick, atrial contraction preceding ventricular contraction. AV synchrony optimizes ventricular filling and thus stroke volume. Loss of AV synchrony, e.g., with VVI pacing and sinus rhythm, can lead to pacemaker syndrome, characterized by symptoms like fatigue, dizziness, and dyspnea due to reduced cardiac output. Improve ventricular synchrony. Indirectly, while CSP directly targets the heart's natural conduction system for true physiological ventricular activation, dual-chamber pacing with AV synchrony still provides better ventricular function than asynchronous ventricular pacing. It ensures the ventricle fills optimally before contraction, contributing to overall better cardiac mechanics. However, it does not prevent the potential for pacing-induced left ventricular dysfunction seen with chronic right ventricular apical pacing. NYHA functional class. Improved hemodynamics and prevention of pacemaker syndrome are expected to translate into better exercise tolerance and reduced heart failure symptoms, potentially leading to an improvement in NYHA functional class. Patient-reported quality of life, QL scores. Patients who experience symptoms related to asynchronous pacing, pacemaker syndrome, or suboptimal cardiac function are likely to report a lower QL. Therefore, improving AV synchrony and hemodynamics with DCLP is expected to enhance patient-reported QL. Evidence from clinical trials, Aveir DR and Micra AV2/AV. Abbott Aveir DR, dual-chamber leadless pacemaker. AV synchrony. The Aveir DR system has shown excellent AV synchrony. Early studies, e.g., the Aveir DR I2I study, demonstrated 97.3% AV synchrony at 3 months, and this was largely maintained at 12 months. Device-based I2I communication success around 90%, which is a surrogate for AV synchrony. This high rate of AV synchrony is a significant improvement over single-chamber leadless devices in patients with an intact atrial rhythm. Safety and performance. The 1-year results of the Aveir DR I2I study showed sustained adequate safety and performance. Hemodynamics/QL, direct data limited at 24 months, while direct 24-month data specifically detailing stroke volume, NYHA class, and QL changes compared to single-chamber or CSP are still evolving. The strong AV synchrony achieved by Aveir DR strongly suggests a positive impact on these metrics. Medtronic Micra AV2, single device, accelerometer-based AV synchrony. AV synchrony. The Micra AV and its successor AV2 achieves AV synchrony by using an accelerometer to detect mechanical atrial activity. The Marvel 2 trial showed a significant increase in mean AV synchrony from 26.8% VVI pacing to 89.2% in patients with complete AV block and normal sinus rhythm. Micra AV2 includes enhanced algorithms to improve and automate AV synchrony settings, reducing the need for manual programming. Stroke volume. The Marvel 2 trial specifically reported an 8.8% improvement in stroke volume as measured by LVOT VTI with AV synchronous pacing using the Micra AV algorithm. This directly supports an improvement in a key hemodynamic parameter. NYHA functional class and QL. Indirect evidence, while direct 24-month data on NYHA class and QL specifically comparing Micra AV2 to other leadless options at that time point is still evolving. The documented improvements in AV synchrony and stroke volume strongly suggest positive effects on patient symptoms and QL, similar to what is observed with conventional dual-chamber pacing. The overall reduction in complications, pocket and lead-related, with leadless pacemakers also contributes to improved QL. Comparison to single-chamber replacement, e.g., Aveir VR/Micra VR. Improved outcomes. Yes, upgrading to a dual-chamber leadless system, Aveir DR or Micra AV2, is expected to significantly improve stroke volume, ventricular synchrony, indirectly by optimizing filling, NYHA functional class, and patient-reported quality-of-life scores compared to a single-chamber ventricular leadless pacemaker, Aveir VR or Micra VR. In older adults who require AV synchrony, i.e., those with sinus node dysfunction and intact AV conduction, or those with AV block and preserved atrial rhythm. This is because single-chamber ventricular pacing, especially in patients with intact sinus rhythm, can lead to AV dysynchrony and its associated symptoms. Comparison to conduction system pacing, CSP. Transvenous. CSP's unique advantage. CSP, his bundle pacing, left bundle branch pacing, aims for true physiological ventricular activation by pacing the native conduction system. This is considered the gold standard for preventing pacing-induced cardiomyopathy and optimizing ventricular synchrony, potentially even more so than conventional right ventricular dual-chamber pacing. Direct comparison with DCLP. Direct 24-month comparative studies between dual-chamber leadless systems and CSP, transvenous, regarding stroke volume, ventricular synchrony, measured by echocardiographic parameters like interventricular mechanical delay, NYHA class, and QL are still very limited or non-existent. Theoretical versus practical. While CSP has a theoretical advantage in achieving true physiological ventricular activation, the DCLP systems offer the benefit of being leadless, avoiding lead-related complications and potentially pocket-related issues, though the Aveir DR does involve two devices. The choice often comes down to balancing the benefits of truly physiological pacing, CSP, with the advantages of a leadless approach, DCLP. For patients where leadless technology is highly preferred due to comorbidities, e.g., venous access issues, high infection risk, DCLP could be a strong alternative even if CSP might offer slightly superior electrical synchrony.
Summary.
Upgrading to a dual-chamber leadless system, Abbott Aveir DR or Medtronic Micra AV2, is highly likely to improve stroke volume, yes, by maintaining AV synchrony. Improve ventricular synchrony, indirectly through optimized ventricular filling, leading to better overall cardiac function. CSP would offer more direct electrical ventricular synchrony. Improve NYHA functional class, yes, by reducing symptoms associated with AV dysynchrony and improving cardiac performance. Improve patient-reported quality-of-life scores, yes, due to reduced symptoms and improved overall well-being.